Welcome everyone to today's webinar, Key Thoughts on Controlling Pharmacy Spend for Hospitals. I am Maggie Moran with Becker's Hospital Review. Today's presentation will be a panel discussion of 6 leaders in the hospital pharmacy space. The discussion will be moderated by Scott Becker, publisher of Becker's Hospital Review. We will have time at the end of the hour for a few minutes of audience Q&A, so if you do have any questions for the Q&A, you can submit them at any time throughout the program into your control panel in the space labeled Enter a Question for Staff and click Send. We will get through as many questions as we have time for. If you have any questions or comments following today's presentation, please email webinarinfo@beckershealthcare.com. Additionally, today's program will be recorded and available for your viewing following today's event. We will send a link to view the recording within a week of today's webinar to the email you used to register. At this time, it's now my pleasure to turn the floor over to Patrick Yoder, Chief Executive Officer of LogicStream Health, to kick off today's discussion.
Welcome everyone. This is Patrick Yoder, CEO of LogicStream Health. This is going to be an exciting and informative session today. As a former hospital pharmacist earlier in my career and now an entrepreneur and co-founder of a health IT software company focused on pharmacy solutions, I'm really pleased that Scott Becker and the Becker's team are generating informative content focused on pharmacy issues. And our company and our software, the Drug Shortage app, are very excited to sponsor some of this activity and content, specifically the e-pharmacy newsletter from Becker's. Obviously, what goes on with hospital and health system pharmacy is an important critical piece to healthcare delivery, and the costs associated with those can be significant. So today's discussion on the key thoughts on controlling pharmacy spend are a very important and timely topic, and I'm very excited to hear this fantastic panel's experience and insight on controlling pharmacy spending. In addition to that, I want to also let everyone know that you should mark your calendars for another webinar on March 27th at 12 noon Central, where Becker's will be doing another webinar that's sponsored by LogicStream Health and the Drug Shortage app. And that webinar will focus on what's trending in hospital pharmacy in 2019. So for more information, visit go.beckershospitalreview.com/what's trending in hospital pharmacy in 2019. Now with that, I'll turn it over to Scott to take it from here.
Patrick, thank you, and thank you to LogicStream Health for joining us today and helping to put these together. So we appreciate it greatly. The topic of pharmacy spend, whenever we talk to hospitals and health systems, has become an increasing concern. We were talking just a couple weeks ago with the system, large multi-hospital system, $5 billion in revenues. The pharmacy spend has grown to $300 to $400 million a year and shows very little signs of letting up. So it's become an increasingly big part of health system budgets and concerns from a long-term financial stability and strength perspective. And at the same time, the need for great pharmaceuticals and the need for great drug delivery because of all the positive things that drug delivery and pharmaceuticals do. We've got a great panel today. We've got 6 different directors of pharmacy and leaders in pharmacy from great health systems to talk about really controlling pharma spend, what works, what doesn't work, what technology works and doesn't work, and what costs seem uncontrollable. With that, as we get started, I'm going to take a moment and ask each of our panelists to introduce themselves. Brad, I'm going to start with you and then work down the list to Randy, Terry, Matthew, Ping, and Neil. We've got a good group today. We'll spend about 8 to 10 minutes on each core question that we're going to go through on the webinar. Brad, can I ask you to introduce yourself?
Absolutely. So Maggie, first of all, Maggie, Patrick, and Scott, thanks for allowing us to be part of this panel today. Very excited about the opportunity. My name is Brad Myers. I'm the Executive Director for Pharmacy and Laboratory Services at the University of Missouri Healthcare, which is headquartered in Columbia, Missouri.
Thank you. Randy?
Yep, my name's Randy Knoble. I'm a Senior Manager of Pharmacy Health Analytics and Drug Policy. I'm also lead many of our high reliability efforts institutionally within supply chain, laboratory, radiology, and pharmacy. The PGI and Residency Program Director, as well as our Pharmacy Director for Pain Stewardship Program.
Fantastic. And Brad, you're University of Missouri. Randy, you're University of Chicago?
That's right. Yep, University of Chicago.
Thank you. And Terry Webb.
This is Terry Webb. I'm the VP System of Pharmacy Executive for Adventist Health West, and we're in California, crossing 4 states.
Fantastic. And Matthew?
Yeah, Scott, Patrick, and Maggie, thanks for the opportunity. I'm the Network Vice President of Pharmacy Services at Honor Health, located in Scottsdale, Arizona, which was a 2014 merger of 2 health systems, John C. Lincoln and Scottsdale Healthcare, about a little over 11,000 employees.
Fantastic. Thank you. And Ping?
Yeah, hi, my name is Ping Du. I'm the Vice President for Outpatient Pharmacy for Baylor Scott White Health. And we are a health system with 40 hospitals, and we own a health plan with 400,000 members. And we also own 30 retail pharmacy, 1 specialty pharmacy, and 1 virtual pharmacy as well.
Great. I'm going to come back at some point and ask you, Ping, about the size of the pharma spend in a system like Baylor Scott and White. We'll come back to that in a few minutes. Neil, let me ask you to introduce yourself.
Yes, sir. Well, thank you, Scott, Maggie, and Patrick, and all fellow panelists. My name is Neil Bullich. I'm Vice President of Pharmacy for Advent Health West Florida Division here in Tampa, Florida.
Thank you. And can I ask a question? It's my dumb question of the day. Are Adventist Health on the West Coast still connected with Advent Health on the East Coast?
Go ahead, Neil. You want to take that one?
At this point, there may be some connection, but I'm unaware of it.
Yeah,
Ping, how did
Yeah.
They operate, this is Terry, they do operate as separate systems, although they're both faith-based organizations from the Seventh-day Adventist Church.
Gotcha. Thank you so much. I know that's an unrelated question. Brad, let me start with you on a topical question. The top drivers of pharma cost today at your system, and if you can, give a sense of the total spend, if it's helpful to people, just to get people get their hands around the sort of core spend in what you're doing.
Okay, thanks again, Scott. So we're a 5-hospital system, and similar to Ping, we have a sort of a institutive retail specialty pharmacy. But if you look at our total spend this fiscal year, we're on track for about $120 million of drug spend when you include inpatient and drugs in the specialty, ambulatory, and retail space. Some of the key drivers, and I think we're all experiencing this across the country, when you really have to think about your business in two different sectors. You have your inpatient spend and then your ambulatory spend, whereas inpatient still tends to be more of a cost containment model, which somewhat depends on your payer status. High commercial mix, which often pays a percent of charge. You could actually be considered revenue center, but in general, your inpatient spend is a cost containment model, whereas the ambulatory clinic retail spend is more about revenue generation, and also some of your basic management tactics, such as inventory management. Some of the key drivers, I think we'll probably hear some repetition through this as we go through each of the panelists. One, drug shortages, particularly think about the inpatient space, are one of the huge drivers that we see day in and day out with old, cheap injectable drugs, which are now going to be high dollar branded products, or even some of the regulatory swings that we've seen with some of our injectables that used to be generic, which are now branded products. On the ambulatory side, it's definitely the specialty medications, your infusions, your injectables, your orals, are driving your expenses on the ambulatory clinic side.
So just to clarify, on the inpatient side, it's more the drug shortages that push you away from generics into branded. And then on the outpatient side, it's more the specialty pharma costs that are the biggest drivers.
Correct. And do recall, it depends on your business model within your health system. It is driving costs. However, it's also a revenue stream for your health system as well. So it's a double-edged sword that we live on right now with specialty medication use.
And let me ask you a question on that. On the outpatient side, more a driver of revenues. On the inpatient side, more a cost. Is that a fair generalization?
I think that's fair.
Thank you.
Absolutely.
I'm going to ask you one other question before I move to Randy. The 120, is that a number that's going up each year, and at what pace is that going up?
It is increased tremendously. This past fiscal year, we had about 102 million for drug spend. This year, we're at 120. Part of that is growth within the specialty areas, however. If you look at our inpatient spend, we've been able to manage that to somewhat flat. I believe last year, about 2.7% increase in drug costs if you normalize for volume increases on the inpatient side.
And so what's happening, costs are up about 20 million, but it's not really a net loss because some of that's revenue generating.
Yes, correct.
Thank you. Randy, let me ask you for your thoughts on what's going on with top drivers of pharma costs at your system. Randy?
Yeah, I'm actually going to probably echo a lot of what Brad just said. Thinking of them, compartmentalizing them in terms of ambulatory retail versus inpatient spend. And I think, when we, and I'm sure many of these other centers on the call, we're attracting those more medically complex patients, which unfortunately result in a lot of new pharmacotherapy that's just been FDA approved. And so I think on top of what Brad said with drug shortages kind of being a trend that's been resulting in a lot of spend in the inpatient side, we've also observed, quite a shift in terms of our ambulatory growth in our retail. And as those patients get admitted to the hospital, figuring out how do we navigate that system, actually put a tax a lot, not necessarily on a direct cost, but more of our indirect costs with just labor to maintain home supply of medication and things like that. So I guess that's the only thing I'd really expand upon.
Let me ask you one follow-up question. University of Chicago is one of the, at least in our area of the world in Chicago, one of the most advanced academic medical centers. I take it as part of that, you see a higher level of tertiary care than a lot of systems just on average. Does that have an impact or play into pharmacy spend or not particularly?
It does. So certainly from the inpatient perspective, our length of stays are a bit longer. Justifying the types of drugs. So example, we have a huge oncology service line here. CAR-T has been something that's been a big thing for us. But as these new leukemia drugs get approved, this is obviously something that we need to think about as well in terms of utilization management strategies. Because many of those you don't have the luxury of getting approval for that drug prior to them getting the diagnosis. So yeah, we do have challenges with that. Hopefully some of that's accounted for with the governmental payers in terms of a DRG. So if we have a more complex patient, hopefully there's some more buffer in terms of the amount of spend that we can have. But I think it's an uphill battle for sure.
Thank you. And Terry, let me get your take on the same question. Just what your biggest drivers of pharmacy costs are. And then I'll ask Matthew, Ping, and Neil just for short answers on this because we'll have hit this question pretty well given our time frame. Terry, let me ask you to add into this question.
Sure. Well, so first of all, we're a 20 hospital system across California, Oregon, Washington, Hawaii. I think one of our, besides what's already been mentioned of the generic shortages and really the specialty market, we have started a journey of standardizing our formulary across 20 hospitals, which is certainly no easy task. And we're finding that just the variations in formulary adherence facility to facility has really added a lot of unnecessary cost to a lot of our at the local facility levels. So we've spent a lot of effort in the last couple of years getting to a single system P&T and managing the formulary from that perspective. And I think the other big question that we're always dealing with is in the outpatient infusion centers with a lot of oncology patients or terminally ill patients that are getting therapies that sometimes are really not tested a lot in large patient populations, and we really don't know their value other than they are very often the last thing we throw at patients. we don't have a lot of evidence yet that demonstrates that many of the drugs that we're using really have a significant impact on the outcome of patients. And so those are the questions and we'll get to that a little bit when we talk about some of the solutions. But really asking the question, does this add value to the patient outcome?
I think it's a great and obviously key question. You're saying with some of the newer things, the more advanced ill patients, the harder it is to really judge. You also mentioned something else, and it was the cost of trying to get your different hospitals to adhere to a formulary. Can you expound on that? Because the concept obviously is you move to a more simple formulary, everybody gets on the same page, and thus you improve outcomes or save cost. But I was hearing something just a little bit more nuanced than that. Could you expound on that just for a moment?
Well, so the short version is historically our organization was a federation of hospitals that flew under a single banner, and we started a journey of operationalizing everybody into a single operating system. And as such, we are now taking 20 hospitals that all independently ran their formulary management locally at the local P&T level and made decisions locally, very often based on local medical staff impressions or desires or their particular opinions, and not always based on evidence. So we decided as an organization to come together as a system and say, let's look at all level 1 evidence and make our decisions based on the evidence, not just necessarily our opinions or experience. And that's been a real journey, I will say, because you can get 10 or 12 or 15 hospitals that say, yeah, we totally agree, and you'll get 3 or 4 or 5 that say, well, we don't agree. And then you have to decide, how do you deal with that going down the road.
Got it. So it's been, even though the idea is clear, we want to get everybody on the same page in terms of evidence-based medication and use. It's been harder to get everybody on the same page than expected, and certainly lots of that different dialogue. Ping, I know you're dealing with a lot of different hospitals. In a couple moments, I want to get to you on that same question. And the same thing with Matthew, too, and all of you, really. Terry, thank you. Matthew, let me ask you a question. Any different thoughts on sort of biggest drivers of cost? And then on the drivers of cost, where you're actually a revenue-generating operation, is it less concerning a problem? Matthew, did that make sense as a question?
Yeah, it does. And, our experience is not divergent from the groupthink. We're a 5 going to 6 hospital health system and have a large focus with the Virginia G. Piper Cancer Care Network. So we have a large bucket of oncology practice, and consistent with the group that, and I think these are national trends, that the cost mitigation on the inpatient side and providing the value of care is critical. We still want to provide good value on the outpatient, but the outpatient is really a growth and revenue strategy more so than a cost mitigation.
Got it. And Ping, let me ask you this question. You've got, in the Baylor system now, the Baylor Scott and White system, 50 plus hospitals or so?
Yeah, including JVs, yes.
Okay. And then what about formulary adherence, trying to have single methods of, single formularies throughout the system? How do you deal with that in as large a system as you have, and also in the joining together, because you were the joining together the Baylor system with the Scott and White system? How do you deal with those issues of trying to get all hospitals on the same page, or don't you?
We also have a system-wide P&T committee, which is the governing body for all the hospitals, and everything needs to go run through the system P&Ts. And I echo some of the other panelists' view that it is not easy to get everybody to the same place. And what we found very useful is, in certain situations, you can place a lot of the restrictions and restrict the formularies and restrict the prescribing to only certain limited subset of specialists, and that would help to mitigate some of the issues. But generally speaking, you want to standardize everybody on the same formularies. And also keep in mind that we also have a 400,000 member health plan where we needs to standardize and in sync with them as well, both on the retail and the health plan side as well. Because if you might be getting a great deal and a great cost saving on inpatient drugs, but when you discharge them to the outside world, your own health plan is paying for it. And if you have a different formularies, then you might actually end up saving money on the inpatient side while costing a lot of money on the health plan side as well. And the same situation is everybody talked about the specialty drugs and all the drugs increase on the outpatient retail side. It's a revenue generator, it's a profit generator. But if we only looking at what's being profitable on the retail side, our health plan is ending up paying for those expensive specialty drugs, and in the overall, you might not still be able to benefit from them. So we do our best and try to align all three different aspects into one consideration.
Right, because you end up being the payer as well, and so the profitability on the outpatient side is largely sort of a misnomer if you end up paying for that as the payer, as the insurer. Let me ask you a follow-up question to this. On the device side, I'm very familiar with hospitals, joint venture hospitals, surgery centers, and so forth, really trying to standardize use by physicians of certain devices, certain implants, where the system feels like they're good enough or they do the job, and they can negotiate price because they're using a lot from a certain manufacturer or a company. And the physicians are constantly pushing back, depending on the system, based on either their belief that a certain device or implant is better, or they're being pitched hard by a device company's sales rep and company. How much of that are you still facing in the pharma area on the specialty side, where, for example, oncologists are being pushed hard by pharmaceutical companies, but you're trying to maintain some control over that? Is that still a very common challenge?
Yes, it is. It's always on the specialty side. Oncology is always the biggest challenge,
and that's where where so much of the cost is. Neil, let me ask you to add into this conversation. I'm going to come back around the table, starting with you, on the best thing you're doing on cost control. Neil,
well,
you'd like to add on cost challenges? Thank you. Sorry.
Yeah. Well, unlike the rest of the panelists, our oncology footprint isn't quite as large, so we are not dealing with the same types of same degree of cost drivers, but we still have some. And I echo a lot of the discussions we had here between the outpatient inpatient business model. They're different, and you handle them differently. But nonetheless, system formularies and a division formulary in therapeutics has proven to be very helpful to attract work groups. Those are physicians or subject matter experts to decide what's best for a fairly diverse division. And so when you take things to the committee, they've already been well vetted by those that would be using the medications. That's always very helpful to win buy-in and certainly make decisions that are best for the division and not just one hospital. But it's a journey, like Terry was saying. It's a journey, and it's not easy. There's the one-offs of the sites or one-off physicians that just don't want to abide by it. But even whether it's outpatient or inpatient, just having your eye on a lot of the different angles to approach whether you have a 340B or not, and optimizing that program. Indigent replacement certainly is key in the specialty pharmacy. So although our footprint is small in oncology and specialty, we still strive to maximize all aspects of product placement, replacement, and price.
Let me ask this question. I want to ask each of you this question. I'm just looking for a 20-second answer. And this is the question, and then I'll get to the more substantive question of what's the most important thing you're doing to drive down cost. I want to start with this question. How significant an issue is the big prescribing physician being stubborn about what he or she uses? Is that still a big issue in systems today, or does it become less of an issue as you become mega systems? How much is individual physician preference still a driver of drug cost, or not so much? Neil?
Well, with systemization and system formulary, it's becoming less and less because those decisions are then put into systems. Systems are then what the only drugs available, and unless you go in, TNF or a non-formulary request, it really does contain things that go outside of formulary decisions. So it's much better today, at least is my experience, than it was before we had systemization and corporate systems of pharmacy.
And Ping and Matthew, let me just ask you that same question really quickly, and then I'm going to come back to the more general question of what are the most important things being done to drive down pharma cost. Ping?
Yeah, I would say so that you do see more physicians getting to more and more compliance in terms of following formularies. And we also use a system to educate the physicians where you can rank them among their specialties and among their categories. So which the physicians are a competitive bunch and they don't want to be at the bottom quartile and they want to be in the top 25%. So when you show them their prescribing pattern and behaviors, it's really helped them to stay in line and to do what the right thing.
One follow-up question on that, Ping. Are the employed physicians easier to get in line than the independent physicians, or you don't see a clear difference, or in Texas, there's not that many employed, so it's harder to tell?
Well, definitely you see the employed physicians are much more easier to work with.
Thank you. Matthew, any thoughts on this question of how big an issue still is the alpha physician who wants complete choice over what pharmaceuticals he uses, or is that less and less an issue as you become bigger and bigger?
Yeah, I think there's an inverse relationship on that from standalone facilities, community hospitals, to larger health systems. But I want to make clear, I think a second part of that equation is resources. It's not just a function of size, but it's a function of resources and data analytics to be able to do some of the data dig at the experience level to understand total cost of care. And then to Ping's point, how do we journey to provide that data with the physicians as partners, and in his example is ranking them so that they're in the top quartile. But I think the data really adds some strength to our discussion, and I think that is a function directly correlated with size.
Thank you. Randy and Brad and Terry, I don't want to jump back into this question unless you have something specific you'd like to add to this question of how big an issue is the alpha physician and not wanting to live with formularies.
Hey Scott, this is Brad. Just one quick addition to the discussion so far. I think one of the advantages we have now as well is just leveraging technology. By utilizing clinical decision support, you can drive a lot of prescribing behaviors through alerting processes or restrictions that are built in within your electronic medical record.
Thank you. And I'm going to come back to some of the best technology that people use. We have an excellent sponsor on the phone, LogicStream Health. I also don't want people to be bashful about naming specific technologies they use for clinical support or for other things, because sometimes that's helpful to listeners to really understand specifics of what you're using. So Neil, let me come back to you. The most successful steps to control cost. What's the most successful things you've done the last couple of years to control cost? We'll ask each person about 60 seconds on this question. A couple thoughts from you, Neil.
Well, it's just analytics. Analytics are key to know where you're spending and dashboard out a division if you can. And the better data you have, the more you can focus your attention and know your risks. And it, it's the old days of 80-20 are enhanced when you have spend analytics available to you.
Let me ask you just a question, and I'll come back to this later. Is there a specific tool that you're using for spend analytics that's specifically helpful?
Well, there's a contracted pharmacy service in this division that provides pretty robust spend analytics data, and that's really been of great benefit to pointing us in the right direction.
Thank you. And Ping, let me go to you with the same question. The most important thing you're doing to control cost?
I definitely think it's the insights. If we are able to view exactly the prescribing patterns, and we're able to view the reimbursement rate, and we're able to view our inventory levels and everything as much detail as possible, that would help us to have a better understanding of our cost, and whether by placing restrictions or getting contracts on large quantity used drugs, or our health plan get PBM negotiations, and those are always helpful. And also by switching to biosimilarity drugs and focusing on generic contract negotiations, that would also help to control the cost as well. So there is not one thing, but you have to do all these things.
Could you do me a favor, just for our audience? You noted about 5 different things. Would you be able to sort of bullet point list those? I sort of heard data analytics and insight, biosimilars, working with the PBM. But if you could help me, just for our audience, maybe you could bullet point the 4 to 5 things you're putting the most priority into.
Okay. I would say that you have data analytics to look into exactly what your cost structures and your detailed reimbursement level. That's one thing important. And you also place restrictions on your formulary. I'm sure everybody is doing it as well. And then everybody is looking at biosimilarities on specialty drugs. That's one area everyone is focusing about as well. And then in terms of contracts, we're looking at for the large spend specialty drugs where we can get a better pricing negotiations. And there hasn't been too much talk on the generics, but yet while generics is cheaper, that's where the wholesalers makes the biggest margin from. So that's one area that we have found is we can drive substantial savings on the generic drug cost as well.
Thank you. Matt, let me ask you to follow on this question. Most important thing you're doing to cut costs.
Yeah, I think the most important thing that we're doing now is how we're evolving on the journey of data analytics. The blocking and tackling fundamentals of P&T work and leveraging the 80/20 reports to work with physicians. I think those days are we've already established that. The challenge with using the 80/20 report in a system approach is the physicians will push back that their patients are sicker, their patients have shorter lengths of stay, they have better reimbursement, so it'd be an advantage for us to provide those medications. So really understanding our data with a robust data analytics and IT infrastructure, and that takes time. That's not something that you can just flip a switch and start moving to, but as we're looking at, cost versus reimbursement, and then as we look at it from a system standpoint, how does that spill over into our health plan, our self-funded health plan, how we're approaching a PMPM for our covered lives, and how do we really stratify those costs versus reimbursement is becoming more and more complex. We've done the fundamentals, probably like most organizations, with P&T and 80/20s and clinical programs, but now we're really ushering in a new age that's going to require a new way of thinking.
Thank you. And you're in as I understand it, a 5 to 6 hospital system, which was the merger of included the Tom Sadbury Scottsdale Health System, correct?
Right. Johnson Lincoln and Scottsdale Healthcare merged in about 2014, 2015.
Yes. So you're still in a spot where and you're still in a spot where with 5, 6 hospitals, you could still look at pockets of physicians, pockets within the system, and say they're spending a lot more than others, where I guess you could still have that in a 50 hospital system, but it'd be a lower proportion of the entire spend typically. But you've already gone through a lot of that work, is what you're saying, really.
We have, and establishing protocols, but a lot of this goes back to relationship management, and even more so on the community-based physicians versus in the employed model. The relationship building and the engagement of the physicians never goes out of style, and even with all the data analytics in the world, building those relationships is tantamount.
Thank you, and that makes a ton of sense. Terry, let me ask you the same question. The most important thing you're doing on cost control, anything specific you could point to and say this has really been successful or effective?
Well, I want to add on what Matthew just talked about, and that is the relationships with medical staff. So there is nothing more valuable than developing strong relations with medical staff leadership, making sure that they are engaged and understanding and part and parcel to the decisions that the organization makes. At the end of the day, if pharmacy makes a decision and tries to roll it out, that will not nearly be as successful as the medical staff making the decision, with pharmacy providing the data and the subject matter expertise. So I think that's really important.
Let me ask you a question on that. In so many systems, we particularly see this on the health IT side, where the health IT people would like to just do IT, but really don't like to deal with physicians. How much of and then you end up with sort of solutions that aren't necessarily used that deeply. How typical is this a problem in the pharmacy world, where the pharmacy team and the pharmacist, if they had their choice, would never have to talk to a physician in their life? Is that common or not so common?
I think we're moving away from that simply because the younger pharmacists that are coming through their training are coming up through organizations where they have to round and interact with medical staff and others. So I think it's becoming less and less an issue. We still have some seasoned veterans, to put it nicely, that are still very comfortable sitting in front of a computer in the basement and don't want to leave. But I think that's a dying breed, and we're moving away from that.
Thank you. So let me just pin you down again. And the most important thing you're doing now, you would mention the importance and echoed the importance of medical staff relationships, clinical staff relationships. The most important thing you're doing to control costs. And then Randy and Brad, I want to ask you the same question.
So we're just now starting the analytics was mentioned, and we use several sources. Of course, everybody dumps information into enterprise data warehouses now, and we're starting to extract that kind of information into using Tableau as a visualization source. We are a Cerner shop, so we also use Cerner's Health Analytics tool, which is a Tableau-based visualization program. So having access to the information, the data, but we also subscribe. Premier is our GPO, and so we do subscribe to their quality advisor, where a lot of the information, outcomes information, goes into this database and allows us to start to visualize if we make decisions on drug A versus drug B, does it really impact the outcome? And nobody's mentioned the two big ones, but I'm sure this will touch everybody's heart. But IV acetaminophen and liposomal bupivacaine has touched everybody's life from a cost perspective, and we've all struggled with those decisions. But when you really look at the evidence and the data, it's very, very equivocal. I mean, there's very little to support either of those products on the market, but we still use them a ton. So the big question now is, can we get at analytics that say, if we don't use these products, do we in fact use more opiates? Do we in fact have patients who stay in the OR longer or go home later, or those kinds of things? And we were able to actually dig into that information and say, when we actually don't see a difference. So even though the industry, and I used to work for the drug industry, so I'm very sensitive to that, even though the industry says this is the greatest thing since sliced bread, if you have data to say that it's not, that's what you got to go on. You have to look at the objective evidence that you've got in front of you.
You got it. Thank you. The ambiguity of the evidence makes it hard to move away from it and make some of these decisions, is what I hear you saying.
Well, it takes somebody to critically evaluate evidence, and you don't need to be a specialist to do that necessarily. So there's this concept of the expert halo effect. I don't know if people have heard of that. There was a good article in the journal not too long ago that just because you have an expertise in a field doesn't mean you know everything there is to know about that particular medication. but the ability to evaluate a study, a clinical study, and the relevance of that study to the practice, that's more important. And that's what we're starting to spend more time doing, the critical evaluation of the information.
Thank you. Let me do this. Randy and Brad, I want to ask you 2 questions each. The most important thing you're doing to control cost and the best technology you're using to control cost. Randy, let me start with you.
Sure. Yeah. I think I'll echo a lot of what my job here is actually to do a lot of that analytics, benchmarking, our performance against peer comparison hospitals. There's a couple different ways you can slice this, and what we're basically 2 years into our high reliability venture, where we're trying to just look at the overall outcomes and cost to figure out how valuable our care is. And so, you know, there's a couple different approaches you can take, and what we're doing here is there's the vertical approach where you're kind of standardizing care pathways for a certain condition or a DRG, using evidence or guidelines to or adapting local expertise to develop those things. Then there's the horizontal kind of cross-cutting approach where you're looking at a specific drug that might be used by a lot of different individuals. And I think depending on how much emotional ties individuals have to a drug, it might make sense to flip that horizontal approach where you're looking at a specific drug restriction into a vertical approach where it's saying, okay, let's just focus on the primary services that are using this and standardized pathways or care so that patients are getting the same thing every time. And we can discuss what value means at that point. And so, you know, the things that we're using for vertical approaches, I think have always been just a piece of paper or something that can print off from the internet, or, you know, some sort of consensus guideline. We're now starting to operationalize that into our electronic health record through a vendor called Agile MD, which allows us to adapt these pathways, and it can be suggestive. So if somebody puts in, if a troponin comes back positive, it might suggest the acute chest pain or acute MI pathway. So that's one way that has been helpful to kind of allow for dissemination of information, since we are a training institute. And then from the horizontal, I think it's just that spectrum of that interventional ladder where you're looking from like nudges, where you're just doing informational provision. The next level would be kind of like working with the carrot and stick model, or peer comparison or accountable justification, all the way to maybe like the shove, which is restriction of choice. So there's a lot of different methods you can use, but that's kind of how we're using, how we're approaching it.
Yeah, no, that's a great explanation. The sort of nudge versus carrot and stick versus the hammer of, if you use this, you're just restricted. You can't use it without a special approval and stuff and so forth and so on. It is fabulous. And then I appreciate the mention of whatever the company name is, Agile MD in this case, for sort of getting some of that information out. So I think it's just helpful. Brad, let me ask you, best thing you've done on cost control, and then what I want to do is, and also best technology or any technology you're using. I'd love to give Patrick one moment to explain his technology, if he's able to, and then I'd also love them to come back around and deal with some of the audience questions we have. So, Brad, best thing you're doing on cost control, any technology specifically you use that you love.
Yeah,
Go
sure.
ahead.
Similar to the other panelists have spoken, utilizing the enterprise data warehouse is key. We're very, very early in this venture, and it's more or less a home built program with Tableau in the background. And our approach has been, we've looked at it from a GPO perspective, so where we outliers at in our top 50 disease states, and then to look at that from compare ourselves with other like organizations. And internally, we have it broken down by each DRG by provider. So if we have outliers, we can identify these outliers quickly. And then typically we pull together a conversation with the provider, the chair of the department potentially. It depends on what the medication and the you know, how political the subject's going to be. But you can definitely hit some easy wins by simply looking at DRG-based pharmacy costs and then comparing your providers internally.
Thank you. In any technology that you've put to work at your system that you're particularly pleased with?
We try to keep we try to keep it a one-stop shop with an electronic medical record. So I think it is powerful when you're able to create clinical decision support. Most physicians are not very excited when you say the word alerts or clinical decision support, but if you build actionable alerts that help drive the physicians to choose the appropriate product, they're much more appreciative. The alerts that just pop and say, don't do this, or this typically are not going to get buy-in. So it does take a lot of leadership within your technology team, your IT team, to work with your pharmacy and your physician leadership to figure out what those alerts look like, how do they fire, and make them actionable as well.
Thank you. Patrick, I don't know if you're still in a spot where you could jump onto the phone for a second. Just take one moment to talk about LogicStream Health and what you guys do, and then I'd love to go back to the audience questions.
Sure. Yeah, I can give it a little overview. So, LogicStream Health is a health IT company, and really what we do and as a company is really all about taking data and actually generating insights from that. So specifically for drug shortages, we basically tackle them really across 3 areas. So the first is, how do you identify them as early as possible? And so we have a mechanism and an algorithm that uses our customer base to provide like an early warning system for our customers on drug shortages, and actually give them some sense of how much of an impact a specific shortage may have for them right out of the gate. We have as part of the drug shortage app also a set of rules with a little machine learning that also basically automates the assessment of that. So it'll take a critical drug shortage and actually help you figure out what are the best communication approaches, what are the best potential alternatives, and then also who and what, or if you should change your EHR workflows to really help control the demand side of the drug inside the shortage while you're trying to manage it critically. And then we have basically workflow tools to carry out those actions. So assign them to people, track them for success or not, and then just even monitor if your interventions that you put in place to manage a critical shortage are actually working or not. And so we do that. We use that same mechanism across many, many different shortages.
Thank you very, very much. I know it's an analytical tool to help people manage better drug shortages and avoid drug shortages and look at choices in drug shortages, and uses sort of the system of nudges that I think Brad or Randy mentioned, and alerts and analytics. So thank you very much. And it overlays well with, I take it, other EHR programs that you're not an EHR yourself, but it overlays well with other technology. Let me do this. Let me come back to a couple questions. We've got a number of great questions from the audience. I'd love to do 2 things. And I'll try and pick out somebody that could answer each question to see if we get some thoughts on it. Terry Webb, let me try and call on you here. We've got this question from the audience on why do some systems work at constantly cutting pharma staff versus increasing pharmacy staff, and often use non-pharmacist consultants to paint the picture of why you had to cut pharmacy staff. Any thoughts on that question and what you've seen over the course of your career?
Yeah, I certainly have some thoughts on that. So we have an obligation as pharmacy leaders to educate the rest of the executive leadership in healthcare systems as to the inverse relationship between people and product. And if we are separating the cost of our supplies versus the cost of our labor and looking at them independently, we're always going to lose. It takes people to deliver care, and the products are simply a part of that equation. So when we have finance leaders in healthcare organizations that say, hey, you've got to cut your drug spend, well, the only way to do that is with the people and systems to make that happen. But at the end of the day, we have to provide care to the patients. Now,
so it's somewhat counterintuitive that you ultimately, to cut pharma costs, which are the pharma spend is so big, ultimately you need a few more people or more people to actually control pharma spend.
Yeah, I've in many organizations, not just my current one, we've found that increasing labor spend has decreased the overall total cost of the pharmacy department. So the disproportionate decrease in supply spend was outweighed by the increase in labor spend. But in addition to that, then you've mentioned the consultants. So there are a host of consultants out there, and they end up being people like those of the panelists that are on the call today that you either retire or decide it's time to move on and do some consulting in the world. And so we take the knowledge that we have and go out and try to make an impact on other organizations. The challenge is, and I've done consulting in my past, the challenge with consulting is you come in to turn the machine upside down and create a lot of change very quickly because that's what you get paid for. The only problem is once the consultant leaves, then everyone else is left to manage the chaos that's been left, which can be done, but they have to understand the process so that when the confetti is up in the air and the consultants leave, now the staff that's left has to do the work of reassembling the new model and reassembling the new business world.
No, thank you. Ping, let me ask you this question. I'm going to ask you just because the limits on time to try and stick to 30 or 60 seconds here, even though that's challenging for all of us, particularly myself. Ping, there's a question of direct procurement from manufacturers and other distributors outside of the primary wholesale. Does that impact costs? Have you been able to sort of do direct buying from manufacturers? Is that really a pipe dream?
In the grand scheme of things, it's not going to impact us because we are such a large organization. But if you're looking at specific drug or disease states, yes, it is. It has a significant impact if you can negotiate it with the manufacturer directly.
Thank you. Anybody want to take a shot at specific things you're doing to reduce oncology spend with use of biological and non-biological agents? Does anybody want to take a shot at that question? Best strategies for reducing oncology spend? Randy, you talked about the oncology that you guys do at University of Chicago. Anything you talk about what you're doing to reduce oncology spend?
It's a difficult space to work in, especially if you're a referral center. But I guess what I would say is focusing on, I think we've touched on variation in care a few times, and I think the more that you can reduce variation for at least your upfront, like developing care pathways, because I think a lot of payers are moving towards a value base, which is kind of following similar to what we're doing on the inpatient side. And so if you were to demonstrate lower cost of total care, maybe the drug is more expensive, but it reduces hospitalization days. So I think almost looking at the macroscopic view of the impact of your system is sometimes the way you have to look at the oncology spend, because fortunately you're not going to be able to influence the price of the drug at the system level necessarily, but you can at least have a predictable way of treating patients, and that standardization in a sense does help take waste out of the system as a whole.
You can look at better overall holistic cost control, not necessarily pricing the drug better, and it's hard to figure out the alternatives to the pharmaceutical too.
Right.
Is sort of what I'm hearing. Does anybody look at the pharmacy staffing from a return on investment model? And Terry, we touched on this for a moment. Is there any data as to, how do you sort of move things so that pharmacists become part of the revenue equation versus the cost equation, or there's a return on investment in the number of pharmacy staffing? Does anybody do a lot of that analysis with their board or leadership in terms of the cost benefit of staff? And anyone can jump in here. I'm not sure if anybody has any thoughts on this. The question from the audience was pharmacy staffing using an ROI model to enhance, better utilization drug models, and whether, better staffing, more staffing actually has a real return on investment. Anybody that's doing that?
This is Randy at University of Chicago. I can pop in real quick. We've just put together a couple of business proposals looking at a couple of different ways. So one was we wanted expansion in our NICU to target inhaled nitric oxide utilization. So wasn't coming out of the pharmacy drug budget, but certainly we thought that a NICU pharmacist looks at the total care of the patient is that continuity, and so we were able to justify that to prevent or reduce the amount of utilization of I&O. But another effective model is just stewardship in general, and so we wanted to look at expanding our antimicrobial stewardship program, and I think it's just figuring out what are they going to work on, and making sure that there's value or money in that. And so unfortunately, a lot of the value that you are looking for is not going to be very easy to find, but I think if you can find certain drugs that they're targeting from a stewardship perspective, that can be helpful to justify.
I have a question, and it's more of a general question from listening in today and listening over the last couple of these, and also talking to some CEOs of health systems. It seems like over the last decade, the position of the chief information officer in systems, elevated from sort of almost a VP level to a true CIO level, and that happened over probably the course of 15 years back to 5 years back, where it became relatively well established as the cost and importance of information systems became so big that the CIO became part of what was truly the leadership of the executive team of a health system. Are we moving towards a spot where the chief of pharmacy or the leader of pharmacy is getting close to that same position, just because the cost level of pharmacy today and sort of the uncontrollability of it? I know one of you mentioned the $100 million, 120 over the course of a year. The same thing, I had a system that's a $6 billion system, now spending $600 million a year. No, I think I have that number wrong. They're spending $400 to $500 million a year, but that cost has gone up $100 million over the course of a couple of years. And does that lead to the person in charge of pharmacy having just a much bigger role in these systems than they did several years back? Is that an evolution that's happening in systems? Anybody want to take a quick shot at that question or observation?
This is Terry. Yeah, this is Terry Webb. So I think what's important to remember is that pharmacists by nature, generally people going to pharmacy are very analytical, which makes us good at our job. Those of us that end up in leadership tend to be much more strategic, and that is really the key to successfully changing the model of delivery, which is what we have to do, because if we keep doing the same thing, we'll keep getting the same results. So we have to be much more strategic, and I think many of the successful pharmacy leaders now are very strategic in their thinking, their planning, and they're working with the people around them that are analytical, that can actually create the work. But we're actually trying to find the new place to go within pharmacy.
Yeah, I know. I think that's exactly right. And it's a fascinating observation. It's really the same observation. If you look at CFOs of systems, you're still in a spot where 70% of them are really drivers of the system, and then 25% are really drivers of the financial and accounting system, and then 25%, and this is a broad characterization, are really involved totally as strategy at the highest level, and doing everything, not just the analytical side of the business. And it's very similar with chief information officers. At one time, just a very analytical group, and then you had a whole percentage of those that ended up being in leadership as well. And obviously that whole mix of, not just great analytical skills, but also great communication skills and desire to be in total senior leadership too. And what you mentioned is very indicative and probably the same kind of evolution as you see pharmacy has become so important to hospitals that they can't ignore it as a very critical part, because it's just so important to their fragility and ability to survive, that I wonder if you don't see that kind of evolution and exactly the kind of personal skills that you're talking about. Thank you. I want to do this. I want to thank everybody on the call, the audience for joining us, Patrick Yoder, the CEO of LogicStream Health, and if anybody has trouble finding LogicStream Health, we'd be happy to help you do so. And then I want to thank our panelists, Brad Myers, Randy Noble, Terry Webb, Matthew Pond, Ping Du, and Neil Bullich. Thank you so much. I find this to be it's a huge area, very important area, and I just love these calls because I learn so much myself from them, and I hope that translates to the audience learning a lot as well. Much of the audience, of course, is at the same level as Brad, Randy, Terry, Matthew, Ping, and Neil in knowledge base, and Patrick. But I hope that even so, that you're able to get a lot out of this call and think about some things a little bit differently and learn something from them. So I'm really thankful to all of you. I'm thankful to Patrick, and I'm thankful to our audience today. And we'll look forward to hopefully seeing a lot of you at events this year at some of our conferences. So thank you all very, very much.
Thank you, Scott.
Thank you.
Thank you, guys. Maggie, we'll wrap up with that. And thank everybody. Thank you guys all. You're just great. Thank you.
Thank you, everyone. That concludes today's webinar, and we look forward to having you join us for future programs. Have a great rest of your day.
Thank you. Thanks, folks.